Hello everybody. This is Dr. Mamegani speaking from Switzerland. Welcome to the next session of the Virtual Global Spine Conference. I'm very excited because I am able to host Dr. Martin Stienen. He is our guest today from Switzerland as well, from St. Gallen. And he's a neurosurgeon, and he is the neurosurgeon head, the co-head of the spine unit of St. Gallen. Just to make sure that you know what St. Gallen is, the Kantonsspital St. Gallen is a huge hospital, one of the biggest hospitals in Switzerland. It's an academic, it's like a university hospital. And who else than Professor Margal by himself was the co-head and the head later from the Kantonsspital St. Gallen, like 40-50 years ago. So famous hospital. It's a legend of spine surgery coming from St. Gallen. And tonight, Dr. Martin Stienen will tell us about his experience in treatment of intradural tumors. So Dr. Stienen is really a neurosurgeon who has seen the world. Not only he worked in different university hospitals in Switzerland, he was also a fellow in Stanford University, and he was in South Korea. And I'm really excited to host him tonight. And Martin, may I please hand over to you to start. Thank you very much for telling us about your experience.
Well, thank you, Alex. Dear participants, I hope everyone can hear me and see my slides. I think that should work. First of all, I want to say that I have no conflicts of interest regarding this presentation or the topic. I want to start right with a case. Actually, that's a case that I did on Monday. And maybe there's neurosurgeons, not only orthopedic surgeons on the board, that tend to have more experience with these type of pathologies. I don't know if you have any idea what that could be. You know, it's a contrast uptaking lesion. It's centralized into the spinal cord. Looks like there's some hemorrhagic lesions, some edema. Well, I'm not expecting an answer, but I operated on this patient because he was showing progressive atactic gait dysfunction, and this is how ultrasound looked when I hadn't even opened the dura yet. You can see the lesion is coming on the surface of the spinal cord where I would plan to enter the lesion. And then when I do these spinal cord tumors, I always think, where are my motor tracts? The pyramid tracts on the lateral aspects, but also on the anterior aspect of the spinal cord. And then I plan, you know, the resection based on this. And now when you look at this picture, this is after opening the dura. There's still like arachnoid layer on top of the spinal cord. You might get an impression what that lesion could be. It's the black lesion that you can see there. Resecting it, it became very evident to me that it must be a malignant melanoma metastasis, and that actually turned out in the histopathology today, and the patient went to rehab today walking without any obvious neurological deficits. That's just one case to start because it was a very recent case. The agenda of my presentation is going to be three things: a short general overview, really quick. Then we are going to dig into a couple of cases and some tips and tricks in the end. And what I like to recall these tumors actually is the good, the bad, and the ugly. Everyone knows this movie. The good for me is extramedullary focal. The bad is intramedullary focal. And the ugly ones are the intramedullary diffuse, or sometimes even extramedullary diffuse. They're a little less frequent. So epidemiology, 4 to 10% of all primary CNS tumors. Incidence is fairly low, 0.5 to 1.5 over 100,000. And when I look at Switzerland, where Alex and I come from, we have about 40 to 110 cases per year. Switzerland is not a big country. We have 8 million inhabitants. So in my hospital, I tend to treat between 20 and 35 maximum per year. So not a huge experience, but some, of course. I mean, There's more extradural, so 55% are extradural, so mets of the spine, some primary bone tumors. And when we look at the intradural tumors, we have the intradural extramedullary. They tend to be meningiomas, schwannomas, myxopapillary ependymomas, neurofibromas, or metastases, sometimes also lipomas. And those that are really rare are the intramedullary tumors. And they are most often ependymomas, can be astrocytomas, or even glioblastomas, very malignant then, hemangioblastomas, mets, but also you have to consider non-neoplastic lesions. They can be cavernomas that can also bleed and become symptomatic. So starting with the first case, emergency admission, July 21, so almost 2 years ago now. It's a 50-year-old female patient who was very fit. She's a cleaning lady, and she felt like there was like knife-like pulsating pain since 4 to 6 weeks, and it was progressive, especially at night. So the lady told me that she couldn't sleep anymore. She had to get up and kind of stretch because it was like a blockage in her spinal canal, she felt. So she went to the chiropractor without any effect. Physiotherapy didn't help either. And then she noticed that there was progressive decrease of sensibility and strength of legs, both sides, and she developed an unsteady gait. Then she fell a couple of times because the legs were just giving way. The findings when we analyzed, when we did an exam on her, she had a hyperesthesia on the trunk, lower extremities with the sensory level at TH10. Gait ataxia. She was really walking like a robot. It was impressive. And she was hyperreflectic on the both lower extremities. Reflex zones were widened. Babinski sign was slightly positive on the left, and she had a preserved continence. So that's an image that we did on her. You may appreciate in the T2, it's a partially cystic lesion. You can see the spinal cord is deviated inside the spinal canal. It's kind of pushed aside. In the contrast agent images, the T1 with contrast, you can maybe see on the axial, the second from above, that the lesion may follow maybe the spinal nerve out in the foramen. So when you see those things, you're always wondering, what could that be? It's an intradural extramedullary tumorous mass at TH9, partially cystic, partly solid. Pretty well demarcated. It's possibly following the spinal nerve into a foramen. So I don't know if there's any guesses what that could be.
Martin, may I ask you, did the radiologist tell you what it is? Was it very clear for him? So did you receive by the report of the neuroradiologist the exact diagnosis?
Well, they're pretty good, but yeah, I tend not to read it too early. I always want to analyze the images myself, and then I check whether I kind of forgot anything important, but I don't rely on them typically with my diet.
Can you please go one slide back, please, to the images? So
sure.
Please, all the participants, feel free to write in the chat box what is your guess, what is the most likely diagnosis. So this is a contrast series, isn't it?
It is actually T2 without contrast and then T1 with contrast. Yes, I didn't.
And the T1 with contrast. And do you order a CAT scan in every intramedullary tumor as well? Do you look for some kind of calcification or any other density that is only visible on CAT scan, or is MRI the only examination you want?
I do ask for CT scans whenever I have the suspicion of a meningioma, for example. We will also have a look at a case with a meningioma soon. In this type of tumor with a lot of cysts, I do not necessarily ask for a CAT scan, but in other cases, I do. I want to know the consistency of the tumor.
Okay, so we have two guesses. One is a neurofibroma, and now we have got 2 times the schwannoma.
Okay, that's pretty good. So I was also thinking most likely intradural schwannoma, could be a meningioma, could be paraganglioma or neurofibroma. All of these are good ideas. So who would operate and how? Maybe there's any opinions on that.
You mean there is the chance of finding somebody who does it conservatively, or do you think there is a possibility of radiotherapy, like stereotactic radiation, or?
Well, the bad thing here is, all the people on the chat did not see the lady walking. If you saw her walking, you wouldn't stay conservative, because she was really walking like a robot. I think probably we can skip that. Who would operate? Of course we did, and we did a laminoplasty here, TH9. It was a very small tumor, partial laminectomy of TH8 just to get a little more above, and then I always say it's an intradural exploration. I always see what I find, and microsurgical resection, of course. And that's the stuff that I need. I need a C-arm to localize, of course. Then I have like an ultrasonic aspiration with a bone scalpel thing for my laminoplasty. I used a microscope for all cases. I have neuromonitoring on board for all elective cases, at least. And of course, I personally like the ultrasound quite a bit. And that's the steps. You localize, then you expose, of course, then you do your laminoplasty. This is how it looks in my OR. We have this, it's a sonopad basically, but you have like this bone cutting tip, and it cuts pretty well. And you can just take out the lamina with this knife. It's very clean and fast, and then you cut the interspinous ligaments here, and then you do the other side. Tuck, 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 tuck. And once you have cut both sides, of course, you can feel that the lamina is getting mobile and is moving, and then you can take it out. I mean, yeah, this is a single level. You can also do it with a drill, but for multiple levels, it's pretty nice to have a Misonics or this kind of device. Okay, and then after that, I like to use the ultrasound just to check that I have exposed the lesion completely. And then I also know I'm at the right level. If I don't see anything intradurally, I have a problem. I have to double check with my X-ray machine. But if I see the end of the tumor, then I know I can open the dura and I can expose everything. And this is how it looks before resection, after resection with the spinal cord freed. And then I put back the lamina with these small titanium devices.
Martin, is there any chance to minimize the approach? Do you always look with the upper ending and the lower ending, the distal, the proximal tumor? Do you expose the complete tumor, or can you minimize it? Can you make a smaller incision?
That's a very good question. I know that there are more and more people that do those extramedullary tumors using like a matrix tubular retractor, for example. You can do that. I like to have a complete view, like craniocaudally. But what I do a lot, this is a bad example for that. I like to stay unilateral. So I do like a unilateral laminotomy or laminectomy, but I keep the midline structures and the contralateral side. So for extramedullary, I like to stay on one side. For intramedullary tumors, I like to see the midline, and then I do complete laminoplasties to have a better view on the midline structures and everything. But you could do this with a unilateral approach.
We have a question from the chat box, Dr. Bagwali. He asked, what is your use of the D wave in the intraoperative neuromonitoring? Do you use the D wave routinely? Is this a big value in your opinion?
Absolutely, but not for extramedullary tumors. But whenever I go into the spinal cord and I'm not too close to the conus, then it's valuable. But we will also have a case where we can discuss this in more detail.
Okay.
Cool. Good questions, though. So this lady did fine, a complete resection. She was doing neurologically very well. The gait was improved very fast, and it turned out to be a schwannoma, and she went to rehab for further follow-up. And I'm showing this because, I mentioned the good, the bad, the ugly. This is a good case. Whenever a neurosurgeon encounters a patient like this, he's a happy neurosurgeon. These are really benign cases. I love to operate. And the lady was happy. She sent me a Christmas card, and we still kind of have a contact. And her 1 year control was fine too. Looking into the next case here, maybe 81-year-old now, so much older, no previous illnesses. She's retired. She also has a similar kind of a pain, was also radiating into the right arm a little bit, no atactic gait, she was walking fine. And also neurologically, she was intact. And the family physician did an imaging on him, on her, I'm sorry, and you can maybe appreciate a small round mass in the sagittal T2 MRI at the caudal aspect. And when you look at the axial MRI, you can see that the mass is on the right side. It's taking up contrast agent. It's pushing the spinal cord to the left a little bit, not too bad. And we also did a CAT scan on her. Here you may be able to see a little bit of calcification, not too much, but yeah, that's the image. And for me, it was an intradural extramedullary tumors lesion at TH4, partially calcified, well delimited. So maybe again, question to the chat. What do you think that would be?
This was really nice. I think I will surely find some answers. The first pops up, and we maybe it's the CAT scan helps I think a lot. So is it a meningioma?
You think so?
Yeah.
Probably. Yeah, I also thought probably it is. I mean, schwannomas can be calcified, but whenever you see calcification, it's very likely to be a meningioma. And would you operate on this lady? I mean, she's neurologically intact. She has a little bit of pain.
So you mean it could be a watch and wait strategy? You could watch and observe whether the patient gets worse. This is the timing of the surgery is the question. If it's a rapid progression, I think everybody would operate. If it's only mild symptomatic, you can watch. Yeah.
I would say the same thing. So for me, it's a relative indication for surgery. I told this lady that, and she said she wants to have the tumor out. It's worrisome to her. I told her it's a benign tumor, but she wanted to get rid of it. But she first wanted to do the garden ready for the winter, and then after that she could have surgery. And that's a very Swiss way of thinking, I think. Yeah. So this is what we did: laminoplasty, one level. Again, could have been done from unilateral approach, totally. At that time, I was a big fan of laminoplasties for some reason. And, you know, when you see this, you know, the tumor is moving, and you think you're very tempted to just take it out like this, but you never know, you know, what's on the dark side of the moon. Is there like a nerve or anything attached to the tumor? If you just kind of mobilize it and take it out like this, you cannot look behind it. You could maybe hurt some nervous structure. So I like to coagulate the tumor capsule, then I can open it. I just take like an insulin needle, as you can see here. It's very sharp. You can easily cut the tumor capsule. And then you can do like a little bit of an internal debulking. You know, here I use an ultrasonic aspirator. You don't need that, you know, it's expensive, but you can also just kind of take the calcifications out, and then the tumor shrinks. So here there's like a little bit of calcified tumor. When you take those pieces out, you know, the tumor volume decreases immediately. And then, you know, the tumor gets much softer, and you can just squeeze it together and dissect it off the spinal cord, which is, of course, your important structure. So here you can actually see how the tumor is kind of falling together. And then you can easily kind of remove it from the spinal cord. So internal debulking and then dissection. It's the way to go, actually. So also
your intraoperative monitoring tells you all the signals without touching the tumor. The signals in the beginning are going down, big change from the baseline. Do you still proceed with this kind of strategy going inside of the tumor, or what do you do then?
I think I would check the blood pressure. I would, you know, optimize that possibly. I would check whether the electrophysiology needles are okay. There's like a technical error, because here when you're not inside the spinal cord, it's very unlikely that you have any signal changes. Actually, a lot of neurosurgeons would do this without any kind of neuromonitoring because they're very benign. You know, remember it's extra medullary, it's localized. It's a very benign tumor type. I would, you know, we use neuromonitoring because we have it. We have the luxury of using it for every case, but you wouldn't actually need it. So here, I think the chance of having any signal change is very low.
Yeah. So is this a safe surgery in your opinion?
Yes, very safe surgery. I wouldn't be worried even if electrophysiology goes down, because I know I'm not touching anything here. Yeah. Okay, so this lady did pretty well. You know, it was a meningioma as expected. She went home 6 postoperative day, and I also followed her up at 3 months and 1 year with an MRI, complete resection. It's a benign case. Those are very nice cases. Moving on, you know, it's a similar case, but you know, the patient was just much sicker, about the same year, but she was geriatric, multimorbidity, very frail, polyneuropathy, recurrent falls. She didn't really hear and see. And you know, people were just thinking that lady's getting old, so this is why she's not walking anymore. However, then she developed incontinence and overflow bladder, and then they kind of scanned her. And when I saw her, I was going to the Geriatric hospital for a consultation they requested. I was barely able to mobilize her. I needed 2 persons, and she could do like 1 step with 2 people standing beside her. And she didn't have, you know, pathological reflexes because of her polyneuropathy, probably. But that's the MRI that the guys did in the hospital. And this looks a little different now because tumorous mass is now very black. Here it's very nice to see it's an extra medullary tumor because you can see the dura actually, and there's a very strong dural adhesion, and black signal on T2 can be blood, but it can also be calcification. And I looked at the images that she had, and we found a PET scan of 2019, and retrospectively, you would be able to see this tumor already back then. So it's a very slow growing tumor, very calcified. It's like a rock. So I think the question what that is pretty simple. It's with certainty an intradural meningioma. The interesting part of this is the way you have to take those tumors out is completely different. This is a rock. This is a calcified hard mass, and it was compressing the spinal cord for probably many years already. So it's very likely that there are adhesions. So what you want to avoid is taking it out, because then the spinal cord will just come with you. You want to avoid downward pressure because you don't want to massage the spinal cord either. Here, neuromonitoring, I think, is very valuable because you don't see what's behind this tumor. And this, I call, this is like the Swiss raclette technique of just carving piece by piece this calcified tumor out. We have this 90-degree cutting. We call it Spätzle tip. It's a very aggressive tip of the ultrasonic aspirator. You can cut bone with it if you want to. And this is very valuable for these kind of tumors. And this is why I was presenting this case. You can see how to take out this mass, and it gets a little softer down below. You can take big chunks out and get the rest of the tumor just with this ultrasonic aspiration device, which proves to be very helpful in these situations. Yeah, were you thinking of Swiss raclette, Alex?
Yeah, it is a must. It is a must. No, I'm an orthopedic surgeon. I can't comment on this technique. I like this metaphor very much. There's a question. The dural attachment of the tumor. Do you coagulate this or do you cut it out?
Yes, very good question. So in these elderly patients, I just coagulate. You know, the likelihood of, you know, tumor growing back is very low. Probably she will die before you see a square centimeter of tumor recurrence. In younger patients, I'm more aggressive. I had one patient who was 25 and he had like an intra and extradural tumor at C1, C2 level. So there I cut out the whole dura with the tumor, and I took fasciolata graft and kind of reconstructed the dura. But for these elderly, typically elderly patients, I would just scratch with a dissector and then coagulate the dura, and that's fine. It works very well. Good question, though.
And do you see whether the accuser, the ultrasound aspirator, the vibrations, do they influence the intraoperative monitoring? Is this a micro concussion of the spinal cord as well, or is it safe?
Good question. No, I think it's safe. You know, you have sometimes some artifacts where you use the bipolar or the monopolar, but not from the ultrasonic aspirator. But you can see here in the postoperative imaging, because the spinal cord was so compressed, now it's expanding. There is some edema, but I don't think it's because of the technique that we used here. I think it was a very safe technique. It's just, you know, the spinal cord expanding after being pressurized very long. And this patient actually did very well clinically. You know, when I looked at the MRI, I was like, whoa, that's bad. But she was walking again. And also I followed her up for a year, and she was, you know, walking stable without a walker in the end. And we had no recurrent tumor. So
when we have a look at this image, it's a fantastic result. It looks very awesome. But an orthopedic surgeon would ask, how many lamina did you take out? It is right under the apex of the thoracic kyphosis. What is your threshold to throw in some screws for stabilizing, preventing post-op laminectomy kyphosis?
Good aspect. You know, to be honest, I have probably done around 100 of these tumors by now, and I had not revised a single one for postoperative instability. And I have not done a single case where I did a priori stabilization. I had one case now recently with a spinal cord herniation where I had to revise because there was still too much edema in the spinal cord. And there, because I needed to create a lot of space and do like a dura expansion plasty, I put screws. I fused that lady. But in these tumors, typically they come very well without any kind of instrumentation.
That's so beautiful. Very beautiful. Martin,
yes.
our audience is a global audience. Many participants come from countries where the average age is a lot lower. Mm-hmm. Can you comment on your thresholds to refuse surgery? Is there an age like 90 years? You wouldn't do it in a 90 years old? Because our patients here, we have a lot of octogenarians. This is our average patient is 80 years old, or let's say 75.
Yes.
Can you comment on this age factor in your decision making?
No, well, good question. Very, very good question. No, we see a lot of very old patients, but that are extremely fit. When I ask them, what do you do? They say, I still go to the mountains. I go sometimes even skiing. And, you know, this is for me, like the functional status, the frailty status, much more important than the age, you know, on the document. The biological age, you know, if they, I mean, and these are not invasive surgeries. I mean, they take 2.5 or 3 hours. Yes, that's true. But the blood loss is like 100 milliliters maximum. So I wouldn't, you know, decline anyone, who is neurologically symptomatic. Not really.
Thank you.
Okay. No, the interesting thing is, you know, because this lady, she wasn't walking very well and she recovered very well. That's an important message I want to send. You know, these cases are extremely benign in terms of recovery. That's a study published in Spinal Cord 2017, actually with malignant epidural spinal cord compression. So completely different disease, but it shows very well. If the patients were developing first symptoms until unable to walk, within 3 days, they would only recover in 40%. And if there was like 30 days of symptom onset until they weren't able to walk anymore, they recovered in almost 90%. So the slower the development of the paraparesis, the higher the recovery of the ability to walk. And that's actually also something I noticed, and I published this case a couple of years ago, and I called this publication Reversible Paraplegia, because that 74-year-old woman actually was in a wheelchair for 19 months, and she only had a little bit of sacral sparing. And I discussed the sense of surgery in this lady, And I told her, I'm sure you will never walk again. However, we can keep this little bit of sensitivity so you don't get, decubitus and ulcers and all of this. And she said, okay, let's do it. And I operated on her, and she went to rehab for 6 months, really long rehab. But when I saw her back in my office, she was walking without a walker 100 meters easily. So it can be amazing recoveries. And she hadn't been walking for more than two years, 1.5 years. So I think this is very impressive, and you should consider that. And this is why I also don't decline a lot of patients, even if they are severely symptomatic. And the recovery can be very good. Talking about younger patients, maybe that's another case. Very healthy guy, assembly worker, 100%, sick leave since a couple of days. And he also reported progressive pain in the thighs, especially at night when lying down. And when I saw him, he had atrophy of the small foot muscles, claw toes, and some weakness, plantar flexion. LASIK sign was bilateral positive. So, you could also think of a lumbar disc problem or anything like this. Yeah, that guy had this on imaging. And, I think all of you will see that this is not the normal conus. It's something weird in there. It's taking up contrast. It's blocking the spinal canal completely. And here I wasn't sure, is it an extradural or is it an extramedullary or is it an intramedullary tumor? I really wasn't sure, but this tumorous mass is completely blocking the spinal canal. And you all know that the spinal fluid kind of flows down and flows back up. There's kind of a circuit, and this is like blocking. And then patients get up at night because they have so much pressure in the spinal cord that they get severe pain. This is pretty typical symptoms. So what do you think that is? Partially cystic, hemorrhagic, a little bit, extramedullary part, but maybe also intramedullary part. Are there any opinions from the audience?
May I ask, you said compression, is this the compression of the roots in the lumbar spine, or is this the compression of the myelin in the conus area? Can you differ this from your point of view, or is this just both?
Here we can count up. So 5, 4, 3, 2, 1. We can estimate the conus is where the little bit of the myelopathy, the edema is, and then I think most of the tumor is really compressing the cauda. It's a cauda compression, but the pain is not so much coming from the nerve root compression, but just really from the blockage of the spinal fluid in the canal. There's like no millimeter space left, and this is why the pressure goes up. And then they have to kind of move a little bit, get up, and then it can flow again, and then the pressure goes back down. This is typical for these kind of tumors.
So we have a clear message from the chat box. It must be an ependymoma. We've got 3 from Argentina, Italy, yes, it must be an ependymoma.
Cool. Yeah, that's what I thought. Most likely maxillopapillary ependymoma.
Dr. Okal even mentioned it's myxopapillary.
Good. Yeah. So, of course, we operated severely symptomatic. We did the 3-level laminoplasty again. This I did with neuromonitoring as usually, MEP as SEP, but I also did a sphincter EMG because, I was dealing with a cauda, and also I used the direct nerve stimulating probe. So whenever I have fiber, I'm not sure if I can, keep it, I can stimulate it. And if I get like a motor response or something, I know that I have to preserve this nerve, of course. And this is how it looks after dural opening. You can see here is like the big chunk of tumor. Up here is the spinal cord. And, I also do the ultrasound evaluation. It has some cysts inside. It's very heterogeneous. And this is how it looks. And then you can take out the easy part, which is the extramedullary part. You can see the cauda equina now, much better, the spaghetti fibers. And the black stuff that's still in there is in the conus. And that's a little more challenging because here in the conus, you don't really see, what is tumor, what is normal nerve. It's all very soft. And you have no way really of monitoring this. You're going into the spinal cord, but you don't have a D-wave electrode, because the D-wave electrode is always distal on the spinal cord. But because that's the most caudal part of the spinal cord, you cannot put it distally on the spinal cord. So it's actually, you're pretty blind on what you're doing. So I was actually, I was not feeling very well. In a very young adult, I was worrying he would be, having sexual dysfunction, avoiding difficulties, all of that. But it turned out that I could remove those tumor parts, and luckily the patient did very well. That's the post-op MRI. You can see like a lack of tumor in there, no contrast agent uptake. And it was a spinal ependymoma, WHO grade 2, and in those we do molecular profiling. You have this MINC amplification. If it's negative, it's more a benign tumor type. You don't need to do adjuvant therapy. If it's a unfavorable tumor, we do adjuvant therapy. I followed this up, this patient for more than a year now, and he actually did pretty well. So I think that's not a good. It's more like a bad. It's not an ugly, but it's pretty bad tumor, I would say.
May I ask you, is there any chance to use all these fancy stuff of intraoperative, maybe not 5-ALAR, but ICG? Is there any possible to identify the tumor intraoperatively?
Yeah, we don't really use that for spinal cord tumors yet. You could use it for maybe glioblastomas, like 5-ALA. They are glioblastomas of the spinal cord, but typically you don't really resect them. You do like biopsy and do adjuvant therapy, or you do cordectomies in very severe cases. You don't try to do like complete resections. It's too eloquent, the spinal cord. So no, we typically don't really use ICG or 5-ALA for these tumors. Should we move on? I mean,
Yes, of course.
This is a younger patient with a familiar von Hippel-Lindau syndrome. She had gait disturbance, clumsy, awkward left leg, and now the left arm was also getting worse and worse. And when I saw her, she was limping. I had an atactic left leg and increased muscle reflexes on the left lower extremity. And that's the image that the lady brought. She was sent to me by one of our neurologists who is specialized for von Hippel-Lindau. And he was already kind of knowing her for many years. And that's an interesting image, because you could think, wow, this is maybe a disc problem with a severe myelopathy. But no, it's not. You can see on the axial, in the middle, the T2, the little hyper intense lesion. And that's very, very typical for this disease. And then in the T1 contrast agent, you see a small lesion. That's almost pathognomonic, of course, with the von Hippel-Lindau disease in conjunction. It's an intramedullary tumor, but very close to the surface, dorsal, well delineated. I think it's pretty evident it must be an intramedullary hemangioblastoma, because those patients, they have a lot of hemangioblastomas typically. And yeah, she was symptomatic, so of course we'd rather go for surgery. What I like to do is I flip the MRI around, and then I put this map of the spinal cord tracts next to the image, and then I always draw the tumor where, on the spinal cord map. And then I was thinking, when I'm planning the approach, where can I enter? Where's my motor tracts, of course. So here I would try to stay, I cannot go in the midline as we typically do, but in the part where the dorsal root entry is, I can go in there, and the pyramid tract will be lateral to the tumor, but I have to respect this, of course. And that's my thoughts when I plan those cases. Of course, with D-wave monitoring in this situation, because the D-wave monitoring gives you very accurate feedback on how your motor tracts, especially the lateral pyramid tracts, are doing. And here again, you can appreciate the beauty of the ultrasound. Of course, you can see the lesion. It looks like it's cystic. Sometimes cavernomas also look like this, but the hemangioblastomas, they are just blood-filled caverns that can bleed pretty badly too. And this is how it looks. And when you expose the spinal cord after dural opening, you don't see this tumor on the surface. So what I do then, you can see it here, there's a little cotinoid placed on the surface of the spinal cord where I think the lesion is. And then I do an ultrasound. It's like a real-time navigation system. And then then I go in where the cotinoid was touching the surface of the spinal cord. That's what I do. And then here I did the tack-up suture of the PIA just to keep it open during the resection. You can gently do that. And then after I was taking out parts of it, I put the cotinoid inside the spinal cord, and then I did another ultrasound. And you can see that there's a little bit of residual tumor, which is still in there. But I like to do ultrasonic controls every now and then, especially for intramedullary tumors, because you don't want to go too deep. So I'm very, very careful actually in those tumors not to go too deep. Does that make sense?
May I ask you, Martin, these are awesome videos, so beautiful, so really beautiful, a big compliment. Usually only Dr. Gargano manages to show us these kind of beauty. The tumor on the right video, the residual tumor or not resected tumor, are these cystic or hemorrhagic findings? Because in the ultrasound, it seems to be a cyst.
Yeah. They look cystic on the ultrasound. I totally agree. They tend to be very bloody little caverns just filled with blood. Yeah. So it's not like some fluid coming out. It's actually really blood. So you try to stay outside of those if you can. But of course, here in a very eloquent region, you go intralesional and you just take a suction device and suck it out. And once the tumor is out, it stops to bleed.
Okay, thank you.
Yeah, you're welcome. So this is actually an MRI that's, I think, done just a few days post-op, and you can see the edema is actually resolving very, very fast. And she did okay. I mean, all of the intramedullary tumor cases, they all slightly get worse. It's very unlikely that they will have no sign of you entering the spinal cord whatsoever. But she had no evident motor deficit, but a little bit of a slight atactic aggravation. And it turned out to be a hemangioblastoma. And she went home, and I followed her until 9 months. And then the neurologist followed her for the further systemic disease follow-up. But she was very happy that we did this kind of surgery. Yeah.
Professor Weiser from Saudi Arabia asked, do you scan the complete neuroaxis in the hemangioblastoma patients?
Yes. They get a complete workup. But I was now focusing on this case. Yeah, but we do complete neuroaxis, retinal examination, checking the pancreas for tumors and all of that. Of course, we do.
Because she has a von Hippel-Lindau syndrome, but also in solitary without any syndrome, without associated to syndromes.
Yeah. I mean, we would check if they have a von Hippel-Lindau, but if they don't, then we would probably just stay local. Yeah. Okay. Next is a 16-year-old apprentice electrician. Actually, he was doing kickboxing a lot, but then he stopped because he would eventually fall, and he also had a progressive gait disturbance. And he was doing electric installations on the ladder, and he felt it was not safe anymore. So something was going on. And when I saw him, he, proprioception was not good, and very atactic gait, and hyperesthesia below TH10. And we scanned him, and you may remember I said the good, the bad, the ugly, right? The ugly are the diffuse tumors. And when you look at this image, you see that actually the whole spinal cord is diffusely blown up. And there may be some cystic components maybe to it, but the spinal cord has become so big, it fills out the spinal canal completely. And when we did contrast imaging, there was a little bit of an uptake there. So it's diffuse, partially solid, partially cystic, a little bit of contrast uptake. I don't know if there's any estimates what that could be.
let's wait a minute. I'm sure there will pop up the diagnosis. This is a 16-year-old patient.
Yeah, he was actually presented by the pediatric hospital.
Yeah. So Professor Baeza says astrocytoma, and immediately I will say this too because he's brilliant. So 4 times astrocytoma.
Good. I think the audience is actually pretty skilled. I also thought it's most likely an astrocytoma. Could be something else. I was hoping for something else because the astrocytoma you cannot resect very well, but the ependymoma you can. So this is also when I thought I do the case. I didn't plan for a biopsy. I was actually hoping if I open up everything, maybe I find some kind of space where I can dissect the tumor out and keep the spinal cord in, but I wasn't that lucky. So when I opened up the whole spinal cord, which just come out, I was thinking, wow, how should I close the dura? It's just so big, you know. And I ended up checking with, I put the D-wave electrode on the caudal aspect, but we were very close to the conus, so the D-wave signal was very unstable. The MEPs, the motor evoked potentials, they were not there at all from the beginning of the surgery, so we couldn't use them either. So it was very it wasn't feeling good going into the spinal cord without any kind of electrophysiological control. It's like a blind flight, when you're a pilot and you have no vision whatsoever. So I kept it at a biopsy, an extended biopsy. I tried to find with the ultrasound some spot that was very pathologic and just biopsied it. And then what I did is I thought, the spinal cord needs more space. So I did this dural expansion patch that I sutured in on the whole length. And I will move forward here a little bit. But you can see we just sutured it with continuous sutures on both sides, of course. And then we put the lamina big, but also with an expansion laminoplasty. So we would always keep like 3-4 millimeters of space between the bony sides in order to give the spinal cord more space. And this is how the post-op imaging looked like. So the spinal cord just used that space, but that patient extremely benefited from that surgery. So he was walking much better immediately after surgery. His balance was back. He had pain sensation of the lower extremities again, which he didn't have before. The histopathology turned out to be an astrocytoma, pilocytic astrocytoma. So actually not a very aggressive tumor, but a tumor that's not so good to resect. And I checked him for 6 months and he was actually doing good. And now he's on follow-up with the pediatric oncologists. And just hoping it will stay stable for long, because I think surgically you cannot really cure this disease. Yeah.
So this in the brain, the pilocytic astrocytoma has got the best outcome when I remember my time in neurosurgery.
Oh, I'm actually very impressed.
And in spinal disease, it's you're limited to a maneuver that is just like we know from any myelopathy, it's just giving space to the spinal cord.
Yes, I think it's unconventional, but here it proved really helpful for this patient. And the nerve fibers, they're just somewhere inside this tumor. I couldn't find a cleavage plane, to take it out. Makes me always aggressive, especially in kids. I hate to not be able to do more for them, but that's the way it is.
Dr. Birchuk asked if there would be any adjuvant treatment. What could this be? Is this radiation? The oncologist would say no, or is there a possibility?
Yeah, well, I know the oncologist and not a radiotherapist either, but I think there's not so much targeted like chemotherapy or immunotherapy either. So probably radiation on this location is probably the first thing that they would do. But here again, I'm not following up on this patient after surgery so long because of the structure of our hospital. And whatever they decided maybe down the road, I'm not sure. I cannot even comment on that so much.
Okay, thank you.
So this is the last case that I presented. It's emergency consultation in June 21, 59-year-old female, history of breast cancer 2 years prior, which was resected with radiotherapy. And she was still on endocrine therapy, but she was doing well, actually. And she presented with progressive burning pain, hyperesthesia, left more than right groin area for 2 months, and then some gait unsteadiness, voiding difficulties. And again, she was atactic, hyperreflexia, no motor deficits. This is the image that we obtained of her. It's in the lower thoracic spine. You can see maybe on the image to the right, on the T2, there's a little bit of a cystic looking lesion, maybe even with a long edema in the spinal cord, going down to the conus, but it was actually going up to C7. We did a whole spine MRI on her. It's a singular lesion, intramedullary, not near the posterior surface, which is not good for us surgeons. Evoking edema, very long, and she has a history of breast cancer. So I don't know if there's any opinions what that could be from the chat. I will put the images back.
It's singular in a patient with a cancer, history of cancer. So the first metastasis pops up, I think, in everybody's mind. From the radiologic point, they could appear, of course, dependent of the origin of the primary tumor. I think they can appear anyhow, but the edema, says maybe it's a metastasis.
Very good. I also think, because also normal spinal cord tumors, they don't do neuropathic pain, not so much, but the metastasis they do. And also the edema is very suggestive of something malignant. So I was hoping for something else, but I was thinking it's probably a metastasis of the breast cancer, which would be evident. So now the question is, who would operate that? I mean, it's very likely a breast cancer metastasis. I mean, typically you would radiate, right? I mean, that's the way. I mean, actually, spinal cord is no-go zone for most. They would just do some radiotherapy and not go in. But maybe I'm crazy, but I thought I would just take it out, and that's what I did. And again, I do this planning, and I'm thinking, where are my tracts? And I took it out with D-wave monitoring. Here I could use very stable signals because it's not so close to the conus. But when I did the ultrasound, I was like, ooh, I have to go very long through the spinal cord in order to get to the lesion. I was feeling a little bad when I saw this. But I could resect the tumor completely, intralesional resection with the aspirator. And the funny thing is now, she did well. She did, she had some hyperesthesia, which she had before, and the left leg was a little less in terms of strength than before, but she could walk and she was happy because the pain was gone. But then the histopathology revealed that it wasn't the breast cancer. It was a melanoma, an amelanotic. Nobody would have found that. And then she received adjuvant therapy and some immunotherapy. And I have followed this lady now for 14 months, and she's tumor-free, and she is walking, and she's very happy. And then I'm thinking, would we have thought it's a breast cancer? She would have received a very different treatment. And this is why I thought I would present this case, because I thought it was interesting. Maybe in some instances it's valuable to take those tumors out in order to get histopathology, because you cannot stick a needle there for biopsy. But that's up for discussion.
Wow, so it's a second malignant tumor. Did they find the origin melanoma on the skin, on the surface, in the intestine?
We never did. So what we did is we did a PET scan on her and an extended workup, looking at the retina and into the even colon and everything, but we didn't find the melanoma. But On the PET scan, we found that there was an inguinal lymph node, which was also resected, but we never found the primary tumor, interestingly. Yeah.
So it's a well done. So I think it's could be we have all surgeons in any specialty have got these cases where the surgery in retrospect was the best decision ever. So the ugly case turned out to be a good one too. The astrocytoma is the bad or the ugly for you? And
for me, the astrocytoma is the ugly. This is the bad one. You know, I'm always a little worried about those cases, but I know they can turn out well. But the diffuse tumors, unfortunately, not. No.
So this is so difficult in neurosurgery. The benign tumor is the ugly, and the malignant tumor is the bad one. It's so easy in orthospine.
Maybe yes. You know, some tips and tricks. Maybe, you know, for us, it's very important to differentiate between intradural extramedullary tumors that are ventral to the spinal cord or dorsal to the spinal cord. I'm showing here a case I could do a couple of years down the road in Zurich when I was still there. It's a very calcified tumor, and the tumor is ventral of the spinal cord. Here, you really have to plan your approach. You want to come from the front or from the back. I did this case from the back. You can see with the ultrasound, the tumor in the front, the spinal cord, very compressed. And then you just have to choose a very lateral oblique trajectory to get to it. And with the ultrasound, you can always check whether the resection is complete or not. And you have to release the dentate ligament in order to mobilize the spinal cord a little more. And, you know, just don't underestimate those type of tumors. They are not so nice. Then you need to know how the nerves are doing. So generous use of intraoperative neuromonitoring, MEP as SAP should be standard. Sphincter EMG whenever you operate in the cauda. Direct nerve stimulation whenever you operate in the cauda, equine. And D-wave, for me, only makes sense for intramedullary tumors, not for extramedullary tumors. I discussed with those patients, with the intramedullary tumor patients, how much risk I should take as a surgeon, because I know I will come to the point where I could take out the whole tumor, but at the risk of the patient not being able to walk anymore. And I really asked to the patient, is it for you more important to have a radical tumor removal, or do you want to be able to walk in any case? And most patients say function for them is more important. This is why in this case that I did this week, I left a little bit of a residual tumor because I was noticing the MEPs were already down by 70, 80%, and the D-wave monitoring was going down by 30% already. I said, I stop here. And the patient is walking. But you have to take these discussions with the patients prior to the surgery, because when you're there and you don't know what the opinion of the surgeon is, then you are very unhappy. So I think that's a very good advice. Yeah.
So this is the principle in skull-based surgery as well, isn't it?
You're such a neurosurgeon. Yeah. Avoid pressure on the spinal cord. So I like really to use the ultrasonic aspiration devices, internally bulking. Then I dissect it off the spinal cord. And I want to know whether the lesion is densely calcified. So generous use of preoperative CT. And then, of course, you know, before I open the dura completely, I want to make sure that I have exposed the end of the tumor, which you can see here, you know, the tumor is ending. If I open the dura and then I see, oh, I cannot reach the whole tumor, and I have to extend my laminectomy or whatever, or drill, then I get a lot of spillage of blood and bone dust into the dural space. And that's not good, because they get arachnopathies, they get adhesions, they can get tethered spinal cord, etc. So just use the ultrasonic device before you open the dura. And once you know you have exposed everything, then you can open the dura and stay very clean. Yeah. And that's we were talking about already. I think you can spare the tension band and the contralateral facet for almost all extramedullary tumors. And especially in the junctional areas, this is important, but I personally favor a bilateral exposure, so complete laminoplasty, whenever I have to go into the spinal cord. I really want to know where's left, where's right, where's the middle. And for this, for me, laminoplasty is easier. Yeah. Maybe just because I think we're running out of time, I wanted to put up a slide here, which for me is very important, because maybe some people on the audience are also exposed or having contact with these patients with intramedullary metastasis. We have just received an AOSpine starting grant that we can do like a multi-center observational study where we collect patients that had intramedullary metastasis, which were surgically resected. And a lot of centers, Stanford, Toronto, but also a lot of German and Swiss hospitals are already contributing. And if any one of you has similar cases and wants to contribute to the study, I'm very happy to get a contact. And I was hoping I can just use this still in the last minute to get some advertisement here.
Yes,
Thanks.
of course. It's so important. Thank you very much, Martin. And this session is recorded on YouTube. And I hope that all this, because we have thousands of participants who use the YouTube channel with more than 100,000 views since 3 years. And we will spread this information on YouTube too. Thank you very much, Martin. This was an awesome session. There's so much to learn, such a good synopsis of intramedullary tumors. We know there are countries like India. We have had a guest from India in a country with 1.5 billion people living there, the possibility to pool them these high numbers. But your session is really good for any resident of neurosurgery and orthopedic spine surgery to learn from the from you. Thank you very much, Martin. This was awesome.
Thank you, Alex. Thank you, all participants.
So next week, another session will happen. Please stay tuned on social media and you will receive the email with invitation. Once again, this was the second session from Switzerland in a row. And interesting, Dr. Stienen knows Dr. Korshi from last week as well. Thank you very much from Baden in Switzerland. Thank you, Martin, and goodbye, everybody.
Bye.